So, sir, we begin. We have touched 100 participants. As
Very good. 100 is a lot.
100 is a good number to start.
Yeah.
And distinguished faculty of this evening's webinar, Sri Upendra Kaul sir, Dr. Suhas Hardas, Professor Mir Jamaluddin, Dr. Rahul Gupta, Dr. Katharina from Austria, Dr. Amat-Santos, Dr. Ramdas Nayak, Dr. R.K. Jain, Dr. Omar Abdul, and all the esteemed delegates of this evening webinar. Good evening to one and all, and good morning to all the delegates from Europe and other parts. We at Relisys deem it to be our proud privilege to welcome you all to this academic feast that would go on for the next 90 minutes. The topic of today's webinar is TricValve, solution for the treatment of tricuspid regurgitation. So this is today's agenda, and we would begin with introduction of the chairperson of the program, Professor Upendra Kaul, and then we hand over the program to Sir to introduce the panelists and the speakers, and then we continue with the program. And for the program today, we have Dr. Suhas Hardas, who is HOD Cardiology from Pune Hospital, Dr. Rahul Gupta from Apollo Hospitals, Mumbai, Professor Mir Jamaluddin, Director, National Institute of Cardiovascular Diseases, Bangladesh, as the panelists. And we have Dr. Katharina from Austria, Dr. Amat-Santos from Spain, Dr. R.K. Jain from KIMS Hospital, Hyderabad, Dr. Ramdas Naik from Cochin, and Dr. Omar Abdul from Barcelona, who would be speaking, sharing out their experiences with TricValve, would be sharing with us the entire topic on the most neglected valve, tricuspid valve. I welcome once again to the chairperson, the panelists, the speakers, and all the delegates, whoever has joined this program. It's our honor to introduce Professor Dr. Upendra Kaul, who is the chairperson of today's webinar. Professor Kaul is a highly recognized name both nationally and internationally, and sir is known for his work in cardiovascular sciences. Professor Kaul is a passionate teacher, an astute clinician who is credited with starting the coronary angioplasty program in India, and he continues to bring innovative techniques in interventional cardiology to the country. Professor Kaul has trained more than 400 cardiologists and has authored more than 400 papers and has written many books. Professor Kaul is a fellow of several prestigious societies in cardiology, both nationally and internationally, and has delivered many named orations. Among the numerous recognitions that Sir has received, he has been awarded the coveted Dr. B.C. Roy Award and Padma Shri from the Honorable President of India for his success and achievement in the field of medicine. Sir, we welcome you to this program. And with this, I give you the responsibility of taking over the program. And thank you so much for joining, sir. We understand it has been a busy day for you. Thank you and welcome, sir.
Thank you. Thank you very much, Ravi, for those wonderful words. And I'm very happy that we have a good audience here to participate in a very important webinar, and that is on solutions for the treatment of tricuspid regurgitation by the TricValve. Now, we know that management of tricuspid regurgitation has been a large unmet need. And as you know, those who have been taking care of patients with, valvular heart disease, tricuspid valve surgery carries a high mortality, and isolated tricuspid regurgitation itself if you have to treat by surgically by, you know, reducing the ring size surgically or putting in a prosthetic valve, it is a procedure which is hated by others because they get into serious problems. Now, one has been talking about how do we manage this non-surgically as we have been doing aortic valve and recently mitral clip and other thing. Why not tricuspid valve also? The initial thoughts would always come that why not we put in a prosthetic or an orthoptic valve in the tricuspid position. But then it was seen it has a lot of challenges because of the big annular size in a tricuspid regurgitation, dilated RA, dilated RV. It can go really very large in terms of its annular diameter. And well, valve in valve and other things have been used if the patient has had a surgery in the past and there's a valve dysfunction, put in an Edward sapien or something there, but not in a de novo valve. It has been a problem. So then one thought of why not, the basic problem in tricuspid regurgitation is what? It is that these large V waves or these pressure waves go into superior vena cava, make your, jugular veins dance. They go down into the inferior vena cava, produce hepatomegaly, produce ascites, produce gross anasarca. And if we could, without getting onto the tricuspid valve, reduce the regurgitation by putting in valves in the superior vena cava, in the inferior vena cava, yet have enough space so that the hepatic veins can drain into the inferior vena cava. Can that be a solution? And that is what we're going to discuss today during these 70 to 90 minutes. And I would encourage participant discussion and participation. We have a number of panelists. You have already introduced them. So the speakers, other speakers, I will just introduce one by one as they come. So let me have the privilege first of introducing our star speaker, Dr. Katharina Kiss, who is from, she's from Austria, where this valve has been made. And she is a very active researcher in the field of interventional cardiology, focusing on minimally invasive surgery. And in 2004, she co founded this company, P plus F Products, uh, which basically was a German technology, and develops these valves. She has, huge experience in this, and she has been, given several awards, including awards by the Russian Federation, Central Asian countries, and I'm sure the Western world and US is just, waiting for her to, be recognized and awarded, and everybody knows this name when you talk about tricuspid regurgitation non-surgical management. Katharina, all yours.
Thank you very much for this very kind introduction. I'm very happy to be back to India, although unfortunately only virtually, but I'm very excited about the developments of the last weeks. And I'm seeing that India is the rising star when it comes to TricValve and tricuspid technology. So I think you have to allow me to share my screen.
Yeah, Ravi, please do that.
Yeah, yes, sir. Yeah, Dr. Katrina, we are able to see the screen.
Okay, excellent. So I'm very excited to talk about the TricValve and the background of tricuspid regurgitation and right heart failure, because I think, as we are all aware, and as it has been very nicely pointed out by Professor Caval, it is not just a valvular disease. We are talking about the right heart disease, and we are focusing primarily on functional or secondary TR, which accounts for more than 80% of overall cases. So we are talking about the dilatation of the right ventricle and the annulus due to either left side valve disease, atrial fibrillation. Of course, we see a lot of patients with chronic pacemaker stimulation, but we do have systemic diseases like Chagas disease, carcinoid, And also today there was a nice paper published about liver cirrhosis. So I think there will be many more to be determined. What is the underlying pathology? Primarily, we are talking about a dilatation of the ring of the right ventricle, and it dilates towards the free wall. When we talk about the tricuspid valve, we have to keep in consideration that it's a multiplanar, three-dimensional structure with a varying anatomy of the leaflets. So it might be very difficult to catch the leaflets by different technologies, but we also have to be aware that we are acting in the proximity of a lot of very important structures when we are treating the annulus, such as the His bundle or the coronary arteries. And of course, we have to keep in mind that the annulus can become huge in right heart disease. If we look at the classification of TR, it has been recently changed. This was under the guidance of Rebecca Hahn and Professor Zamorano, who is also our ECHO core lab for the TRICO studies. So the classification has been added, massive and torrential, to classify the really severe TR and to give us more ideas about how massive this can be. What is the prevalence? I remember when we started with the TricValve, I was convinced that we are talking about a niche product. But then I started screening in my own institution, and we of course started to do research on the numbers, and these are numbers from US, where we have a prevalence of 1.6 million cases with an annual new appearance of 250,000 cases. And what is very interesting is that although there are around 50,000 surgeries for mitral valve in the US, the number of tricuspid valve surgeries is below 8,000, so it's a very low number. If we look at the prevalence of aortic stenosis, mitral regurgitation, and tricuspid regurgitation, I think it is very important to understand that actually tricuspid regurgitation is more frequent than aortic stenosis, especially in certain populations worldwide. So we are talking about a huge field of patients that is needing help. Why is it important to treat TR? Well, if we look at those papers from Mayo Clinic, but also from Vienna, Austria, we can see that the presence of TR by itself is an independent marker for impaired outcome. So we can see that even in the presence of moderate TR, we can already see survival heavily impacted. The same with the combined endpoint here for death, heart transplant, left ventricular assist device implantation, which was more often reached in the presence of moderate or severe TR. And the same is true for patients with impaired left ventricular function. I think this is a very important slide. This is a work from the Mayo Clinic, and it showed that in the presence of TR, yearly mortality, atrial fibrillation, and heart failure hospitalization become much more frequent. So if we do have valvular disease, death amounts to up to 30% per year, which of course are huge numbers. So the combination of left-sided valve disease, atrial fibrillation, and heart failure increases mortality dramatically. And this is something that we also saw in our patient cohort. Actually, the majority of the patients do either have prior left-sided valve surgery, or they are in AFib and have pacemakers. So what happens if we just treat the mitral valve? Will this solve our problem? Actually, it will not. If we look at those publications, then we can see even after correcting the mitral valve, in the presence of moderate or severe TR, we still have a problem. We do still have a severe impact on prognosis due to untreated tricuspid regurgitation. And this is also true if we look at a combined procedure of mitral valve procedure and TAVI. Here, for example, mitral clip and TAVI, but also in other combinations. And also there, if TR is present post-procedural, then it has an impact on prognosis. Why don't we put those patients to surgery? Would be easy. We do a lot of mitral valve surgery around the world. Well, I think because we are not treating a valve only, and also as Professor Caval has already pointed out, it's not a solution to just close the tricuspid valve, because those patients will go into right heart failure and mortality is unacceptably high. Even if we look at these numbers of in-hospital mortality of being only like 8.8%, we have to take into consideration that the majority of the patients we want to address with, for example, the TricValve will be denied surgery. So they will not be even in the vicinity of surgery because they are frail, they have comorbidities, they have prior surgery. So I think for those patients we are targeting, surgical repair is not an option. Now we know that there are a lot of different devices that have come and many of them have already gone again. The majority of those are mimicking a surgical approach, such as the Vega or Hetzer stitch, annuloplasty device, such as the CardioBand, and of course the coaptation devices, which are most frequently used in patients at an earlier stage of disease. If we look at valve replacements, there are some animal studies, very early trials with orthotopic valve replacement, but the TricValve is the only available technology for heterotopic valve replacement for tricuspid regurgitation. I think this is also a very important slide. And if we look at this, then we see that we can divide tricuspid regurgitation and right heart consequences in three phases here if we look at secondary tricuspid regurgitation. And we can see that phase one with only mild tricuspid annulus dilatation, this might be suitable for annuloplasty, but mostly those patients do not have a lot of symptoms or any symptoms. If we look at phase two, then we have additional moderate tricuspid annulus dilatation, but we also start having a tethering of the leaflets, which makes it more difficult to address them. If we enter phase three with severe tricuspid annulus dilatation and the tethering of the leaflets with preserved mild to moderate right ventricular function, then actually there is very few choice about from which to choose from. And here actually the TricValve is the only one commercially available. So I think, and this is important, if we look at the choice of devices, these are numbers from Spain, then we can see that after the mitral clip on TriClip, Cavi and TricValve was the most frequently used in Spain here, and we have done over 50 cases in Spain over the last year, which I think is remarkable. If we look at this patient population, and this is something I just want to point out because I think it's important to see that here the majority of the patients are in AFib. They do have pacemakers. Of course, the majority is functional. These patients are almost all in NYHA class 3 or 4. They do have peripheral edema and they have previous admissions for right ventricular failure. So we do look at the very ill patient cohort. I think this is like the most important consideration if we target those patients, because we have to take into consideration not only demographics, clinical symptoms, comorbidities, cardiac disease, and surgical characteristics, but of course we have to take into consideration TR severity, the annulus size, tricuspid valve morphology, how far has the right ventricle already remodeled, how is my pulmonary vascular resistance, and all of these factors have to be taken into consideration when the heart team is making its decision. And I am convinced that at the moment we are very easily passing the point of no return. We are treating too late in the course of disease because, of course, for many, many years, we did not have any option. Now, a lot of patients are lined up that have a long-standing disease, but I think it's very important to choose patients that have not passed the point of no return, patients where we can expect response and their consequently recovery. Why is it important to have a good device that is safe and that you can deploy with a lot of confidence? Because procedural success is associated with reduced mortality. And this is not only true for clipping and other procedures, but also for TricValve. And here we have seen that the procedural success is extremely high, which will be also pointed out later by my co-speakers. So in conclusion about TR, functional TR is common and it's associated with a poor prognosis. The majority of the patients are currently not being offered any intervention. And we hope that transcatheter options may be impactful in many patients that are denied surgery, but the timing of the intervention is crucial. So a very important message from this, I'm really congratulating relisys on this, is to increase awareness in order to make patients earlier accessible for tricuspid valve intervention. And this might help to avoid patients reaching end-stage right ventricular failure and allow treatment of patients who are most likely to benefit. So with this, I would like to lead over to the TricValve transcatheter Bicaval valve system, which is a system consisting of 2 valves. I just want to show a short video in order to give the audience some idea about the mode of implantation. So if we are looking at the heart, of course, we have in the course of disease, we will have a dilatation of the annulus and a more and more regurgitant tricuspid valve. This will lead in consequence to volume overload and congestion. So if we look at the cava superior and inferior, we can block that backflow into the cavas by introducing the trick valves. So here we have the one in the superior vena cava. In a second step, the inferior vena cava valve is implanted, and they will effectively reduce backflow and in the further course promote remodeling and reduce congestion. So this is a set of 2 dedicated valves, which is unique worldwide. You have on the left side a valve which has a short skirt. This is for the inferior vena cava. It has a double funnel concept, and the short skirt is designed in order to prevent paravalvular leakage, but also blockage of the intrahepatic veins. Whereas if we look at the more round valve here, which is for the superior vena cava, we can see that it has like a crown which folds into the confluence, and then a belly which will anchor it in the superior vena cava, and the valve bearing segment which faces towards the right atrium. Both of those valves are self-expandable. They are nitinol valves, and they do use a special bovine pericardium, which is also done in-house. We are using dry tissue technology, which I think is really crucial because it makes the technology much safer. It's much easier to handle the valves. The team size will be reduced, and of course, it's a matter of safety. So these valves come pre-mounted, and the only thing you have to do in the cath lab is to flush them for about 3 minutes with saline. If we look at the preclinical testing with this pericardium, then we can appreciate that the calcium content is lower when compared to standard pericardium. There's a decrease in thickness and an increase in tensile resistance. And we saw in the durability testing that actually the dry pericardium is superior, and we do have an integrity of collagen structure. So for the trick valve, they are implanted percutaneously into the inferior and superior vena cava without disturbing the native valve. I think this is of extreme importance, as you can also consider later treatment of the, for example, the annulus or the mitral valve, even going through the inferior vena cava valve. So it's especially intended for patients at extreme risk who are inoperable for surgical therapy. It comes in several sizes, and due to the self-expandable character, it is able to cover the majority of the anatomies. This is how it looks like, and this is from our CT core lab from Valladolid, from Dr. Santos, who will also present afterwards. So once the valves are in place, it is there to avoid backflow, to reduce congestion, and to remote right ventricular remodeling. So what we see is a reduction of symptoms, and in a long run, of course, we would like to decrease mortality. This is again on the valves, but I think you're already familiar with this. This is the inferior vena cava valve. And this is a nice short video that I would like to present, although we are seeing a case afterwards. So I would just like to send the message that it is good if you have a CT overlay technology, you can actually reduce fluoroscopy time and of course also the use of contrast by overlaying your CT, which is very important for the screening procedure, with your later procedure. So this is how it looks like, and actually these clinical recommendations are taken from the CE trial, so they might be a little bit stricter that we will finally handle it in real life, but I think it's good to keep them in mind because like this you have a guidance on which patient should be considered. So the first step after determining that the patient has severe TR is a CT scan in order to check on the anatomic suitability, and then there are certain factors which should be kept in considerations. Very important is the V wave, which should still be present, and the TAPSI, which should still be above at least 14, because we have to have a right ventricle that is still at some extent functioning in order to have the backflow, in order for the valve to be functioning. These are the measurements which will be in the beginning guided by a team from our side. This is how it looks then in the implanted position, and very nicely also here from an animal model. So in conclusion, for the TricValve, it's a very easy, straightforward procedure. It has a very fast learning curve, which I think is important, and a very high overall procedural success. This will depend very much on the quality of your planning, as always or as many times in structural heart disease, of course. Due to the fact that the valves are already pre-mounted, there's less human manipulation. You are accessing via the vena femoralis, which of course gives you a very low risk access site. And also in case of venous bleeding, there is no severe consequence. You can recapture the valve up to 90% of deployment, which I think is important, although with good planning, you will not need it in the venous side. There is no general anesthesia needed, so you can do the patients in sedation with transthoracic echo only, which I consider very important in this very ill patient cohort. And you have a good visibility. It's suitable with pacemaker patients as well. And you have a lower risk of contamination as the devices are pre-mounted. And I'm very happy that you will hear more about the TRICOS trials in a minute. And I want to thank you for your attention, Dhanyavad.
Thank you, Dhanyavad, for giving such a lucid talk. And it was great. And while I was listening to it, I was reminded of scores of patients which I remember by names who were, in front of me getting into very well functioning mitral valves, aortic valves, but tricuspid regurgitation, ascites, liver coming up to umbilicus, jaundice finally, and succumbing to that. And today I was just thinking, and they were young patients,
Yeah.
if we had this technology, I could have saved many of such patients, but the future is there, and we will not allow those patients to get into problems now. Thank you so much.
Thank
And
you.
thank you. So now it's my pleasure to bring in Dr. Ignacio Amat-Santos. Maybe I'm not pronouncing his name well. It's a Spanish name. I love Spain. I've been to Barcelona. I've been to Madrid. But he comes from a different city called Valladolid in Spain, and I'm sure that one of these days he will invite us there so that we can really have this glimpse of the beautiful city. Also, it's very interesting that Dr. Santos is also adept in a lot of coronary interventions. He's an expert in CTO, and he has done Science 28 trials and all that. But he has been in this valvular, intervention field with TAVIs and mitral, and now finally he's going to give us the data of the clinical aspects of tricuspid TricValve deployment and also the outcomes. So here you are, Dr. Santos. How do you spell your name? How do you pronounce your name?
I'm Ignacio Amat-Santos, Dr. Caval. Thank you very much.
Okay, thank you very
Thank
much.
you very much. And of course, you are well invited to visit Valladolid whenever you want.
Oh, great, great.
Thank you so much. I'm very honored to receive this invitation to share my experience. Okay, I will start sharing my screen. Thank you. So I have been modifying my presentation while Dr. Kiss was talking because I don't want to be repetitive. So we already have a nice overview by Dr. Cole and Dr. Kiss about the rationale of this concept. But I want to stop in this slide that has already been shown, just to highlight that although there are several percutaneous devices with clinical evidence currently, still the 1-year mortality for this population overall with these techniques is up to 1/4 of the patients, so it's still high. This is why when we show this kind of techniques and this proposal of management made by my mentor, Dr. Rodés, we can see that there are several alternatives for primary TR, several alternatives for secondary, but CAVI alternatives were left for a very advanced degree of the disease. Probably this is too late also for this technique, and I think what I believe, according to the findings that I will share shortly, is that probably we should implement this technique earlier in the evolution of patients. And why is that? Because the right ventricular dysfunction is often more severe than what we estimate. So TAPSI might be 15, 16, 17, but the RV is already very dysfunctional. And this means that if we use an orthotopic device, probably this acute reduction of the TR will cause an acute deterioration of our patient as well. If we see very briefly what we know about other techniques, with TriClip we have very limited experience. It is true that it's considered successful in a high proportion of the patients, but successful was considered reduction in 1 degree of TR, so that means from torrential to massive, from massive to severe, and means that in a high proportion of patients, we left untreated a high degree of tricuspid regurgitation. And also in this early experience, in very experienced centers, there were 5 cases out of 85 with single leaflet attachment or detachment of one of the leaflets. So it's still a technique that needs to improve the results. If we move to navigate, this only published the compassionate clinical use, and we discussed this in an editorial in the JACC intervention recently, and we have seen a mortality up to 12.5% at 30-day follow-up. This is very high mortality. More than half of the patients required inotropic support after the technology, and this means probably that we are selecting candidates that are too late for this technology. And finally, if we discuss about Cardioband, the clinical experience is still very reduced, about 30 patients. And although technical success was also considered very high, you have to see that more than 1/4 of the patients have moderate or severe tricuspid regurgitation at the end of the procedure and in the follow-up. And the mortality at 2-year follow-up was also 1/4 of the patients. So, what represents CAVI alternatives? It is true that it is a less physiological alternative, maybe. We still don't know the long-term outcomes of these patients, true, but it's also a less invasive alternative, less complex from a technical perspective, and this is very important for the generalization of this technique. And it also allows a complete reduction of the backflow to the hepatic veins and to the superior vena cava and to the inferior vena cava. But this is not a new concept. Why we are not using it since many years ago? Probably the reason is that despite the high success rate, more than 90% in the initial publications with this technology, there was a high rate, almost 10% of conversion to open heart surgery. The reason for that is that we were using devices as Sapien or direct flow that were not dedicated to this technique particularly. This means that the complications were higher, of course, and it was also associated to a similar mortality rate to what has been reported with the other percutaneous technologies. But now we have two Cavi alternatives. One is Tricento. This is a customized device that we have used in our center. They have reported clinical improvement and positive remodeling, but there was a technical issue. 14% of the patients presented a stent fracture of the device that made it stop in the market. And then we have the TricValve technology that Katharina already presented very nicely in the previous talk. And it's a technology that we have been using under strict imaging protocol, which is crucial for the good outcomes. This might seem very simple because it's a stent implanted in the caval veins, but we have to be very strict with the recommendations that were also presented. And I'm going to show very rapidly the case because I know we are seeing more cases later, just to show how simple it is if we follow the recommendations. So you can see the 27 French introducer, so delivery system. Of course, the procedure has to be performed slow and very calm. The patients are always very stable. This is a procedure in the right side of the heart, not in the left side. So you can see the deployment of the belly and the rest of the superior vena cava valve and its final release. Then we remove the delivery system and we can advance another delivery system that is exactly the same as the first delivery system. So it's mounted in the same French size delivery system. And here we can see the implant, also very simple, but very slow, and taking care of the positioning according to angio, if possible with fusion, with CT, as was already mentioned, and with echo guiding that can be transthoracic or transesophageal, as in this case. So this was one nice case that we performed in our institution. We have already analyzed several CTs from candidates to this therapy, and we have seen several findings. First is the superior vena cava is very short and very tapered. We have to aim for a very high implant to avoid risk of leak or embolization of the device. This is very important to know. If this distance is shorter than 45 millimeters, we have to be careful. And for the inferior vena cava, we have also found out that if the angulation of entrance to the atrium is more than 15 degrees, we have to be careful. We have to implant it very low because there is always some small movement when we do the final release. So we have to avoid a leak. As Katharina saw, the upper 2 centimeters are sealed with pericardium, but not below that. This is why we can implant in any case, even if the hepatic veins are very close to the atrium, which is not feasible with other similar technologies. And this is one example with a 3D printed model where the superior vena cava was very short and tapered. So we have to protrude into the right atrium. And you can see next to that, the actual patient and the model, the 3D printed model, showing that the implantation was exactly the same. This is a cadaveric model. We can take the landmarks for the implant. This is the superior vena cava. We can see the confluence with the innominate. This is where we will implant our valve to avoid sealing with the pericardium the innominate vein. And here we can see the entering the azygos vein into the superior vena cava. And for the inferior vena cava, we have discovered now that there are many, many different shapes, and probably those more angulated in the entrance have higher risk of less perfect positioning. So these are the more challenging cases, as for example, for left atrial appendage closer, the chicken wing or other challenging anatomies. And we also find out that there is some innervation around the inferior vena cava that might cause some pain irradiated to the shoulder of the patients, that it's transitory, but is to be taken into consideration. It's not a complication. We don't need to repeat the CT. We know that this is due to the innervation in this location. Also, we have learned a lot about imaging. Sometimes there is a very prominent Eustachian valve that precludes the contrast from going into the inferior vena cava, and this will make challenging measuring the inferior vena cava. And here, the echo is very helpful to determine the sizing of the device appropriate for the patient. And now I will move in the last minutes of my presentation to the preliminary results that we have from this technology. The source of this data is triple from the Special Access Program with 100% success procedures, from the early feasibility trial with 9 patients, and from the CE mark trial that has already been completed with 35 patients, but I have available data from the first 29. So I will present the results from this global cohort of 38 patients. This is the kind of patients that we have been treating in the trial, very similar to what also has been treated with compassionate use. As you can see in the TricUS study, there was almost 20% of the patients with prior pacemaker, which is a very high rate, especially if we compare with those that we can treat with TricLip, Cardioband, Navigate. So this is a very good alternative for patients with pacemaker. A high rate of renal failure, and more than 50% of the patients with prior valve surgery, most of them in the left side, but also in the right side, also failing annuloplasty. If we go to the results, we can see 100% of success in the implantations, no stroke associated to the procedure. In the first trial, the 9 patients, there was 1 conversion to surgery, and this was a result of embolization of one of the devices. There was a learning curve, of course, but in the TricUS Euro, there were no conversions to surgery. And importantly, in the last few cases, we were able to perform the procedures with local anesthesia and no need for transesophageal echo. This is a very frail population, high risk of bleeding population. So avoiding intubation and avoiding transesophageal echo will reduce likely the rate of complications as well. Functional outcomes have demonstrated a significant improvement in NIHA class, and also a trend to an improvement in quality of life questionnaires. But please take into consideration that this was limited because it all occurred during 2020, which means that the walking of the patient was limited due to the COVID pandemic. If we move to the functional outcomes, there was also loss in weight. There were no changes, importantly, in TAPSE, right atrium area, pulmonary pressure, and left ventricular ejection fraction, according to the echo analysis. There was a significant reduction in the diameters of the right ventricle. And when we analyze the CT in the core lab, we can see a significant decrease in the ratio of the right ventricle and left ventricle that has been already associated with a prognostic positive impact. There were 2 cases, as you can see, where we found in the CT control at 3 months some thrombi, but importantly, it was not impairing the function of the leaflets. It was attached to the stent and was likely in relationship with a poor control of the anticoagulation. Probably these patients need to receive vitamin K inhibitors and not NOACs. This is a learning point from this experience. And also, if we move to the hemodynamics, we can see that there is a significant decrease of the backflow to the hepatic veins and of the V wave in the inferior vena cava. No changes in the lab analysis in creatinine, NT-proBNP. And in summary, there were no device-related mortality. There was 1 procedural-related death, 1 patient with a complication due to the intubation with a fistula tracheoesophageal. There were these severe events, 1 hematoma in the access site, 6 cases of respiratory infection, 2 admissions due to heart failure, and 1 death that was unrelated to the heart causes. It was due to a fall with subdural hematoma. So my conclusions are that TricValve system is a new, promising, and less invasive in concept for the treatment of TR. The successful and uneventful initial experience shows that it is feasible to apply this therapy as compassionate and clinical use. The TricValve was associated to an improvement in functional class, quality of life, and also in the hemodynamics. And therefore, if we are able to confirm this in a larger number of patients and at longer follow-up, this may open a new avenue for the treatment of tricuspid regurgitation. Thank you very much.
Thank you very much, Dr. Amat-Santos, and it was very useful learning your experience and presentation of the data, which is evolving. As you said, that this was done it's not a old technology. This is a new technology, still evolving, and I would say that it is matured now. And I'm sure that year 2021, we're going to have a larger experience. And in our next presentation, I'm sure the presentation would have, three digit or maybe more than that patients, and we get much more confidence with that. Thank you so much. There are a number of questions, and we're going to have a good question answer session. There are very important points which many of our colleagues are making. So before we move next for the cases, let me introduce one of my good old friends, Dr. Mir Jamal. Dr. Mir Jamal, he is the director of the National Institute of Cardiovascular Disease in Dhaka. I visited that hospital many times. I'm sure he remembers that. And he is the Secretary General of the very prestigious Bangladesh Society of Cardiac Interventions. He is also the Vice President of Bangladesh Cardiac Society and also course director of a very popular program, Bangladesh Radial Intervention Course. He has been trained at many places. In fact, he has been trained in Delhi. He was in Escorts Hospital. I was also there that time between 2001 and 2002. He has been to Korea. He has been to Japan and also had some experience with imaging in Chennai in Apollo Hospital. He is life member of many societies and is also, started the Bangladesh Society of Echocardiography, for which he was the joint secretary. Welcome, Professor Jamal. And we really wish that, it was a physical meeting, not a virtual meeting, so that we could have seen each other and hugged each other. Now, is Dr. Rakesh Rahul Gupta here? Anyway, when he comes, we'll introduce him. So let us go to the important part of case presentations. And let me request Dr. R.K. Jain, who is a very good old friend of mine. He is the founder director of Krishna Institute of Medical Sciences, has numerous awards, is an illustrious career, and he has participated in many trials, and he has been one of my main investigators in some of the trials which you have published in New England Journal of Medicine, like Tuxedo, and we are expecting him to do the same in Tuxedo 2. And he has been associated with Indian Heart Journal, many awards, various publications, and is one of the very active persons in bringing in new technology to this part of the world. So let me request Dr. Jain to present his case and Indian scenario and his experience with TricValve. Dr. Jain.
Thank you very much, sir, for such a nice introduction from a legend like you. We're all followers of you, and we follow many of the things what you teach us. So again, I thanks Releases and we met Dr. Katharina many times and a little experience about this TricValve in our center in Krishna Institute of Medical Sciences. Dr. Katrina has nicely explained all the things, and I will not go to the details how you evaluate these patients and what all the things we do. I'll go to some of the cases which you have done. This is the first patient who is a 50 years old male. We did this in July 2018. This patient, he's a patient of chronic rheumatic heart disease post double wall replacement, both aortic and mitral in 2004 in the same institute. And patient now presented with right heart failure. And the patient had a severe organic tricuspid regurgitation. There was no evidence of a pulmonary artery hypertension, and patient was in right heart failure. And echocardiogram, I'll just share the echocardiogram. And we suggested that the patient can't be taken for surgery because he's already a double wall replacement. And again, now, as all of us know, the mortality is quite high with again surgical mortality with a tricuspid wall repair or replacement in this situation. So we had a heart team approach, and they said if you can do some percutaneous method. So we talked to the family, and we went discussed with the family and went ahead with this TricValve implantation. And this is a severe tricuspid regurgitation you can see in this patient. So I will, the steps have been enumerated. And in this patient, we also took an extra, this was 2018, as I said, and this was one of the first cases in the country we did at the time. And this was the transjugular, left transjugular access also we took to make sure that we implant the valve well. And we have also kept the catheter in the pulmonary artery, and we have kept a pigtail catheter in the left brachiocephalic vein to make sure that the valve is implanted well. You can see the surgical sutures and the aortic mitral valve, and this is how the SVC looks. And then you can see the lower part. This is where the landing zone should be there. The valve should not go. As Katharina said, if you have a fusion of images of CT and echo, it will be wonderful for this procedure. The need for contrast decreases, the embolization of the device also decreases. But I think there's all the new labs, and once we have these new labs, I think we can use a facility. And this is the catheter in the pulmonary artery to make sure that the bulbous portion of the wall remains above the pulmonary artery catheter. And this is the SVC wall. And this is exactly where the wall has to be deployed. And we got a good deployment of this wall. And that is where the bulbous portion of the SVC wall is implanted. And then we have kept from the left femoral vein a catheter into the hepatic vein to make sure that hepatic vein drains into the right atrium and is not obstructed by the wall. And this is the IVC wall. And you can see there is some radio opaque here where the wall is above this and below this, and this is where the hepatic veins drain into the right atrium. And you can see once the wall is deployed, you can see the hepatic vein drainage is not obstructed by the wall. And this is very, very important when you do these type of procedures. And this patient, now we have 2.5 years follow-up. He's doing extremely well. There is no embolism or thrombus in the wall, and the device is functioning well. And he never got admitted to the hospital again with right heart failure. He's able to attend to all his work and duties. With this experience, we got more referrals, and this patient, we got a referral from empathy. And this again was much sicker patient. Again, he had a post DVR, and all of us know that in India, a lot of these patients are there. As Professor Kaul said, that he saw so many of these, and then we continue to see these type of patients, sir, in our practice. And this patient had a severe TR, and this patient was admitted at least 3 to 4 times in different hospitals with right heart failure with an ascites which needed tapping. So, and we counsel the family that this is an option, and we may not assure a fantastic result. If you see this echo, you can see there is a gross dilatation of RA and RV, and is incompetent tricuspid wall. And there was no PA, the PA pressure was 50 when we did a right heart cath, less than 50. So the patient was eligible, and we counsel. So we used a 29 size stick wall, SVC, and 49 size IVC wall. And this is the angiogram. And as the earlier speaker from Spain said, you have to be very careful when you select this wall. And if there is not much landing zone, initially we thought we will keep in the right jugular vein, but when we did the pictures, it was not going to fit. So this is initial strategy, but we had some difficulty there. And that's why we implanted the wall in the left brachiocephalic axis, partly into the left brachiocephalic axis. And this is how we implanted this wall, and we got a good result. And this is how the wall, and there is no risk of embolization. And we went ahead with the inferior vena cava wall, which is less tricky in these procedures. And this is how the sketch diagram show the inferior vena cava is identified, and the inferior vena cava is deployed. Unfortunately, this patient came for one follow-up, but within 3 months, the patient died, probably because of intractable ascites. So the lesson we learned, as Dr. Katharina said, it should be done at the right time. You should not wait too late where there's no point of return. And that's what we understood from this case. The third experience we have, again, a very complex case. This patient had a Ross procedure in 1997 at Delhi. And following that, in 2009, he had issue with the pulmonary wall, homograph conduit. And again, he had a pulmonary wall replacement in 2009 with RVOT reconstruction. And now he presented with the tricuspid regurgitation, which is a functional tricuspid regurgitation, right heart failure, and atrial fibrillation with a controlled ventricular rate. When we did the CT imaging, we got a recommendation of SVC TricValve of 29, IVC was 41. And this patient, the valve was specifically manufactured for this patient. In fact, these valves were not available, but right now they're easily available with this company. So, but we have to wait a couple of months to get this valve because it was specially ordered for this patient, and we got this valve of 49. And in this patient, again, as a routine with experience, we tried to implant the valve, but as the Spanish speaker, I am not able to get his name. He said SVC valve. My experience have shown that SVC valve, you have to be really careful, because if there are they have a straight shape, there's a chance of embolization is quite high, and that's what happened in our patient. You can see the bulbous portion of the wall has come below the pulmonary artery, and there's a more amount of valve is protruding into the right atrium. And this is the second arrow shows the wall that should have been there, the first arrow, and it has slipped the wall. So what we did, we took a Coda balloon and tried to snare from the opposite side and tried to push the wall. And this is what we did. And what we did, we thought we'll fix the upper part of the wall by using another stand, 14 into 40 Zanes and bare stand mounted on the wall. And we came it from the jugular vein, but unfortunately, while deploying this wall, the wall got embolized, and this is what happened. And then we luckily captured this wall, this stent from the femoral approach, and we again tried to reposition the wall, and we thought it's reasonably okay to keep the wall there. But there was we waited for a couple of hours, and then the wall was not migrating, and we thought quite confident the wall will not migrate. And we went ahead with our IVC deployment IVC wall, and it went on uneventful. This patient, 1 year follow-up, this patient we did in December 2019. He was doing fine, but last follow-up we came last week. He has worsened. The liver has become more cirrhotic, and he's gone into low albumin, and he needs repeated hospital admissions for his cirrhotic liver. So again, we learned from this case that whenever you try to do these type of procedures, you have to do before no point of return. That's very, very important. And what my experience has said, I'll share my last case again. This is again a patient with a double wall replacement with a tricuspid annuloplasty did in 1994 in the same institute with where I am working in the same group, and she's been a follow-up till 2020. And now she has developed a severe tricuspid regurgitation, pedal edema, ascites with RV dysfunction. And this patient again was offered this as a therapy, as a surgeon was not willing to take up for a redo surgery with a tricuspid valve repair because the risk is quite high. And again, this patient also needed a large IVC valve. And again, we ordered this valve from this company, and we got the 41 IVC valve. And again, we had a mishaps in this case, and you can see this huge cardiomegaly. You can see the huge right atrium. And here, if you see the angiogram, the SVC is more of a straight SVC rather than a conical shape. And this is where you're supposed to implant. There's a RV, RA, and SVC junction. And this is how the SVC looks, and this is how the RA looks. And while implanting this wall, the wall got migrated. And by doing all the tricks, still we couldn't prevent, and the wall embolized finally into the right atrium. So after a couple of hours, we didn't have any strategy to do. So what we decided, we allowed the wall to embolize and ask our surgical colleagues, if they can explant the wall and reposition it to the SVC. And they were willing to bail us out. And then these are all the tricks we did. None of them worked. We tried to snare the wall from above by using a snare. It didn't work out. And these are all the tricks we did. And then once we all got exhausted, the surgeon said, we'll bail it out in the morning. What you do is you implant the IVC wall now, and then we'll take her up in the morning and take out the wall. So when we're doing deploying, deploying the IVC wall, we allowed the SVC wall to embolize further and deploy the IVC wall. And the next day, our surgeons took out, did a right atrial thoracotomy, retrieved the wall, and re-implanted the wall in SVC position successfully. This patient did fine post-op, but post-procedure after 30th day, patient developed sepsis due to an unusual organism, and the patient died. So summarizing what little experience with this tricuspid regurgitation requires a very careful patient selection based on clinical and hemodynamic criteria and device-specific anatomic criteria. SVC wall, you have to be more careful. I think the professor from Spain has shown that so many types of SVCs can occur in this with his experience, and even so many types of IVC also is telling, which we are not known, because if angulated SVC, there's a chance of embolization again, which with the 4 cases experience we didn't have. And hemodynamic criteria, force for us, all of is easy. And what I feel, I'll put a point to the audience here, is if the patient has multiple admissions with right heart failure and needing a tapping, I think these patients are at no point of return. I think these patients has to be carefully excluded from this therapy. Otherwise, the therapy will lose the value, and more patients who really deserve the therapy might not get the therapy. So it's a safe in selected patient with tricuspid TricValve and results in complete resolution of Caval plaque, as we have seen in the first patient, extremely doing well. These are all registry data. We have to see how mortality and morbidity benefit will get, and then more randomized clinical trials are needed for this type of therapy. Thank you very much.
Thank you very much, Dr. Jain, Rajinder, and I'll request you to stay back because there are a number of questions, and we will, maybe exceed time also, but go through all the questions. And Dr. Amat-Santos also is going to tell us something more about, the intricacies of this after we, see more cases. So with this, I think let me introduce our friend Dr. Ramdas Nayak, who is from Kerala, and he has been very active with the coronaries as well as valves as well as pacemakers and TAVI, and he is also one of the persons who has started this program in the state of Kerala. He is a very good teacher and has various publications, and he's going to talk to us about the severe organic tricuspid regurgitation, how he treated this patient, and as Dr. Rajendra Kumar showed, by it needs a very good vision to share the problems, because showing a very good goody case is very good, but at the same time we should be aware of what could go wrong and what should be avoided, so that same mistakes are not committed by others. Okay, Dr. Ramdas, please.
Are you able to see the screen?
Yes, very much. Very much.
Audible too. Okay. Thank you, sir, for the kind introduction. Thank you, Relisys, for giving me this opportunity to speak to this august audience. And greetings from Rajagiri Hospital. Salutations to my mentor, Dr. Prakash Kamath, who is everything for me, because of whom I am sitting here and talking to you. So this particular patient is very challenging, as not shown by Dr. Jain. It was not challenging during the procedure, but throughout the course of this patient when he was with us. He's a 72-year-old male, was diagnosed to have coronary artery disease, double vessel disease, right ventricular EMF, atrial fibrillation chronic, not on OAC, because of hemoptysis, hypothyroidism, and partial loss of vision of right eye due to retinal bleed. And this patient used to get admitted every third month to hospital for the last 3 years. And he presented to us this time with shortness of breath, which was progressive in nature. This is echocardiogram when we saw him. You can see that RA and RV are dilated with mild RV dysfunction. This is how the TR was. It was gross TR with dilated IVC, which is non-collapsing. So after examination, and the final thing was we diagnosed him as the one which coronary artery disease, double vessel disease, severe organic TR with moderate RV dysfunction, TAPSE of 1.1, atrial fibrillation with controlled ventricular rate, anemia, hypochromic microcytic with iron deficiency, hypothyroidism, chronic kidney disease. There was no evidence of RV EMF according to us, and gigantic RA and hugely dilated IVC, which is non-collapsing. As usual, as everybody treats, we also treated him with diuretics and, of course, started on vitamin K antagonist, and he developed hemoptysis and had hyponatremia. Had to stop vitamin K antagonist and started on a low dose of Dovac, dabigatran 75 milligram twice daily. Added on tolvaptan because he had hyponatremia, which was significant, which was less than 125. Subsequently, in a month later, he presented with difficulty in swallowing, loss of appetite, and weight loss. Gastromedicine consultation was done. OGD showed esophageal ulcer and healing antral ulcer. Initiated on medication and improved. Patient continued to have dyspnea, and this time we discussed with him about the tricuspid repair, both surgical as well as percutaneous. The case was discussed with the surgeon, and since the RV dysfunction was severe and it was an isolated tricuspid valve repair, the mortality being high, the surgeon said, we'll keep it on a hold. They never refused, but they said, we'll keep it on a hold, let him improve, then we'll see it. Subsequently, after 2 months, he again presented with hemoptysis. This time we switched from dabigatran to low-dose rivaroxaban with 10 milligram. Pulmonary consultation was sought and symptomatic treatment initiated. There was a drop in hemoglobin. Oral hematinics were initiated. 2 months later, he presented to ER with bilateral edema, scrotal edema, and ascites. This is because he stopped and went for an alternative medicine. The scrotal edema was the scrotum was as big as a basketball, and both the limbs were as big as the elephant limbs. A weight gain of 20 kg from the last visit. Examination anasarca, atrial fibrillation, severe RV dysfunction. This is how it was looking this time. The RV had really deteriorated from the previous view it was. Again, the patient stabilized with inotropic support, IV diuretics, developed hemoptysis on heparin, hyponatremia on diuretics, USG abdomen, early cirrhosis of liver. Discharged after 1 week in a stable condition with low-dose diuretic, Dovac, and the supportive medications. Patient doing well for the last 1 month, accepted more than usual for his Christmas, and presented to the OPD with bilateral pedal edema and increased severity of breathlessness. Admitted and initiated on decongestive therapy. Workup for tricuspid repair initiated. Chest CT showed no evidence of any mass lesion, bronchiectasis. There was moderate cardiomegaly with dilatation of right-sided chambers. And of course, chronic parenchymal liver disease was seen during the chest CT. He was admitted for percutaneous tricuspid valve repair workup. So CAG revealed insignificant coronary artery disease. Right heart showed pressures of 50. Again, more than 60 is a contraindication where he had only 50 millimeters. RV angiogram showed no RV apical obliteration with adequate RV function. Cardiac MRI was performed, dilated RA and RV with severe TR, adequate RV and LV function. This is the RV angiogram during which we had done and showed adequate RV function. This is the MRI, which shows severe TR and dilated RA. So workup for anemia, since the patient always had anemia, wave up to 7 to 8 milligram, and we started on erythropoietin, discussed the case with in a hearty meeting for a surgical repair of tricuspid valve since the RV function was good. And again, another 2 months later, presented to ER with massive hematemesis, hemoglobin of 5. Ogeriscopy showed minor esophageal varices, active duodenal ulcer. Stopped DOAC and initiated on low-dose enoxaparin 0.3 milligram twice daily. Repeat endoscopy on 7/5/2020, that is about a month later, and ligated grade 2 esophageal varices as the patient need to be on lifelong oral anticoagulation post implant. Waited for another 2 months, did well, no bleed, improved quality of life, able to do his routine activity, and was admitted for Bicaval implantation. Now the challenges: AF needing lifelong oral anticoagulation, bleeding diathesis, hemoptysis, hematemesis twice, chronic anemia, cirrhosis of liver with esophageal varices, which is being hemoclit, hyponatremia on diuretics, and choice of oral anticoagulation post-implant, as the patient is unable to take vitamin K antagonist. And there are no studies which have said that DOAC is helpful or can be used post-implant. So these were the challenges, and it was a very difficult decision. The patient we had already procured the valve much in advance in December to do the case. And because of all these untoward incidents, we had to postpone every time. And this time we decided that this patient needs some treatment because he is coming with recurrent heart failure. This is exactly how the procedure was performed, as shown by the previous speaker. The pigtail was placed in the RPA. This is exactly to guide the valve. This is angio done. You can see that the RPA crosses exactly at the just above the RA-SVC junction. This is another wire just to place at the roof of the RA to know that the distal end of the SVC wire is exactly at that particular point. So this is after placing. Just want to make sure that everything is positioned. We had a peripheral line on the right side. We just injected it and everything looked perfect as the belly was looking just above the RPA. And this is how it was deployed. Subsequently, angiogram at the hepatic vein was done. You can see that. Again, the skirt has to be just above the hepatic vein, and this again was deployed rightly there. Just to see whether there is any endo leak there. This is how it looked in TE post-implant immediately. Both the valves are in position with no much of issues. Post-implant management, we went with enoxaparin 0.3 subcutaneous BD for 6 months. I was fortunate to have discussed this case with Dr. Katharina, and this is how we thought of, after discussing with her, to give enoxaparin for 6 months, then decide on how to go about it. Subsequently, right now, he is on rivaroxaban for 4 months, since last 4 months. He has no hyponatremia since the requirement of diuretic dose is very minimal. It's about 5 milligram of torsemide. Hemoglobin stable between 9 and 10 since he has no bleed. He had 2 untoward incidents, not related to procedure though. He had a spontaneous left knee hemarthrosis requiring aspiration in the 4th month after implant. and an accidental fall with an injury to the left elbow and forearm leading to hematoma, which is conservatively managed. 10-month follow-up, which is last week. Patient doing well, able to do all normal activities at ease, no admissions for cardiac-related issues since the procedure, no hemoptysis or hematomesis, adequate biventricular function with normally functioning valves. This is how his echo is currently, and he is doing well. Thank you all once again for the patient listening. Thank you for the opportunity.
Thank you very much, Dr. Ramdas. It was a fantastic case. So sick, all the comorbidities, and lucky that he has done well in spite of having ascites and all the things which increase the, the long-term morbidity, and he's done quite well. Very good. This also reminds me, Prakash Kamath, your mentor. I miss him so much. He was my student at All Indian Institute of Medical Sciences, just to think straight. So thank you so much, and I at this stage welcome one of our moderators who has joined us, Dr. Rahul Gupta, who was got busy somewhere, and he's finished his case and he's with us. Dr. Rahul Gupta works in Apollo Hospital, Navi Mumbai. He has an experience of more than 15 years. He is a very talented person in the cath lab. He does acute MI, complex angioplasties, and all the things, intravascular imaging and functional assessment, pacemakers, and he has been one of the pioneers in that. He has implanted the first leadless pacemaker, Micra, I believe, and bioabsorbable stents. So he is a jack of all the trades in cardiac cath lab. So Dr. Rahul Gupta, please be with us, and we'll participate in the discussion.
Thank you very much, sir. Thank you.
Thank you very much. And with this, now we come to the next case, and the next case is by Dr. Omar Abdul Jawad, and he comes from the city I'm so fond of, Barcelona. Wow, Rambilla Street, and sitting on the road and eating nice things. He has a very illustrious career, many publications, and he is also one of the pioneers of doing this procedure in his city, in his hospital, and is a big, good academician. So Dr. Omar, please show your case.
Thank you very much. It's an honor to be here with you. I've been in India also 3 times. First time 20 years ago when I was a student in Patiala. I spent there really nice 2 months in the college in Patiala. So there I released the high quality of the doctors in India. So for me, it's an honor to be here and to share my experience with you. Let's go. So for my clinical case, I divide in the case in a clinical screening, anatomical screening. What I'm going to show you what we used to do with these cases in our hospital, and after I'm going to explain you some procedural and post-procedural aspect that maybe they can be useful. Next slide. So for the clinical case, this our patient is an 82-year-old woman with a previous chronic kidney disease. The cardiovascular history, she has paroxysmal atrial fibrillation, and this patient underwent to aortic and mitral valve replacement plus CABG in February 2019. Pre-discharge, the echocardiogram show quite normal left ventricular ejection fraction, normally functioning of the prosthesis implanted, mild right ventricular dilatation, mild tricuspid regurgitation, and systolic pulmonary pressure around 48. So patient was referred to our center 1.5 years later in June 2020 because right heart failure. At that point, patient weight was 67 kilo. Patient was in NIHA functional class 3. Patient presented semiology of tricuspid regurgitation and had signs of right heart failure. So a patient was referred to the heart failure clinic. We start diuretic treatment with furosemide till 120 milligrams per day, plus eplerenone, and also with vasodilatators as hydralazine. However, patient improved the signs of heart failure. However, still presented in a poor functional status with NIHA functional class 3 and walked only 100 meters in 6-minute walking test. Also, the lab tests show an important elevation in the increase in the proBNP. We repeat the echo, and the echo show a new free functional tricuspid regurgitation, a very severe massive tricuspid regurgitation, probably secondary to the annulus dilatation, with still preserved, quite well function of the right ventricular with ataxia around 15. And the rest of the parameters of the valve previously implanted were okay. So we did a right heart catheterization that show important increase in the pressure in the superior and inferior vein cava with a big wave around 30 millimeters of mercury. The pulmonary artery pressure was not very high. The mean was around 25, so it's almost normal. So, and the patient was rejected for a new cardiac surgery. So in summary, we had the patient with severe functional TR with important big wave in both superior and inferior vein cava, with right ventricular function still preserved, not significant pulmonary hypertension, but poor functional state with NIHA class 3 and only 100 meters in 6-minute walking test, despite a good medical treatment, and the patient was rejected for conventional surgery. It was the summary of the clinical screening. For an anatomical point of view, we perform always in a CT scan for sizing, for planning the procedure, as I think that the key marks that we use for planning this is for the superior vein cava prosthesis is diameters at the level of the confluence, diameters at the level of the pulmonary artery, and diameters at the level of the junction between the superior vein cava and right atrium, and also the differences, the distance between these points. As you can see here in the right picture, the morphology or the shape of the superior vein cava looks like optimal for TricValve because there is no tapered shape of the superior vein cava. And there is enough space to fit the valve. For this particular patient, we choose TricValve 25 millimeters for the superior vein cava. The anatomical screening for the inferior vein cava, it's important to take into account the transition, the diameters at the level of the transition of the right atrium and the inferior vein cava, and also at the level of the hepatic veins and below the hepatic veins. So in this patient, we also have a big distance between, well, not big distance, but a distance between the superior hepatic veins and the junction with the atrium. We think that this is important because if the distance is too short, the case is very challenging. If you remember what Dr. Kiss explained, only the first 20 millimeters of the proximal edge of the inferior valve is covered by the skirt of the valve. So we need to implant this part of the valve between the superior vein cava and the atrium. So in this case, we have enough space for fit the valve at this position. Also, we can observe in this patient that there are not big angulations between the atrium and the inferior vein cava. So for this particular case, finally we choose a 41 millimeters prosthesis. Okay. So the procedure, what we did, in this case, we choose 3 axes, right femoral and left femoral axis, right for the device and left femoral for the pictet and swan guns. But also we choose a basilica vein axis just to have a better visualization of the confluence between the innominate and the superior vein cava. In this case, we performed the procedure under general anesthesia. As Dr. Amat-Santos explained, probably this is not mandatory. And we did the procedure under TE that it can be very helpful for the inferior vein cava deployment, but probably it's not mandatory. Well, this was the angio of the superior vein cava. As you can see here, the shape of the superior vein cava, it's not very tapered as the cases that we have seen before. This is a good candidate for the TricValve. There is enough space, it's long for fit the valve. So for the inferior, there's a little bit discordance, the angio, the CT scan. If you remember, in the CT scan, there are around 15 millimeters between the superior hepatic vein and a right atrium, but in the angio looks like there is this distance is shorter, and this is probably because the inferior vein cava entered into the right atrium. So for this particular case, maybe the TE can be very helpful for the deployment of the inferior valve. So this was the baseline TE during the procedure. Before the procedure, there are some catheters there. It's a 4 chambers view when we can see in a free TR, probably secondary to the dilatation of the tricuspid annulus, with a sign here of high right atrium pressure. You can see the septum bombing into the left atrium. So this was the baseline pressures of the right atrium and the superior and inferior vein cava that looks like or remind the right ventricular pressure curves. So we have a very high B wave, around 30 millimeters of mercury, but also the morphology of the curve looks like a ventricular morphology. So that means that the TR is very, very severe. For the deployment of the superior vein cava prosthesis, we used to begin to start the deployment as high as possible, because the system, you can pull down the system during the deployment of the valve. However, you cannot push the system. So our recommendation is to start as high as possible and pull down until we arrive to the final, to the target position that we want to put the device. If we want to replace, to readjust the position of the valve in a higher position, probably we have to retrieve all the system and start again in a higher position. Here we can see the catheter in the innominate that will be useful for the reference. Also the swan guns placed in the pulmonary artery. So our target is to implant the belly part. It is the part with highest radial force, probably between the pulmonary artery and the innominate. Here was the deployment where we wanted to implant the valve between the pulmonary artery and also the innominate. If we put the valve in a higher position, there is a risk of innominate occlusion. If we put the valve in a lower position, there is a high risk of migration, as we have seen in the previous cases. So this is how looks like the superior prosthesis in the TE. For the deployment of the superior vein cava prosthesis, TE it does not give a lot of information we can avoid, but it's still always interesting. But what is interesting is the decrease in the V wave in the superior vein cava. You remember the previous pressure with a morphology of right ventricular morphology in the superior vein cava, and now we have a more normal morphology of the wave with a V wave of 40. So for the inferior, here we used to do an angio of the superior of the suprahepatic vein, just to put similarly than with the superior prosthesis. We start deployment in a high position, and after we pull down until the final position of the prosthesis. For this maneuver, you need to maintain a lot of tension, as this is a nitinol device. Nitinol always tend to go out from the delivery system. So my recommendation here is to maintain a lot of tension until we have deployed the 80% of the device. Once we have deployed the 80% of the device remains very stable. Even we have to release the tension to avoid an unbounded effect into the right atrium. So this is, remember that only the 21st millimeters of the device are covered by the skin of the valve. So our target is to implant this first 20 millimeters between the atrium and the suprahepatic veins. This is the final result, how it looks like in the angio and in the TE. You remember, in this case, we see that the inferior vein cava enter into the right atrium. So the angio sometimes can be a little bit confusing, but the TE was very clear. So we implant the valve here. There is no big problems. This was the final result with the curves in the inferior vein cava. You can see that now the V wave is 13. We change the morphology of the curve of the pressure, and also inside the right atrium there was a slight increase in the right atrium pressure. This is in the acutely after the implantation of the device. As a post-intervention care, shoulder pain, in our experience, shoulder pain is a common symptom that usually is very benign and disappears within the first 72 hours. But sometimes there are some patients that still present pain after 3 weeks. We hypothesize that probably this shoulder pain can be caused by the compression of the sensitive phrenic branch of the phrenic nerve caused by the inferior vein cava. If we have a good experience with gabapentin in these cases, the only problem is gabapentin maybe takes 2-3 weeks to start to work. The follow-up of our patient at 3 months, a patient improved the functional class. It was a functional class 2, improved significantly the 6 minutes walking test, 168 meters. Also the Kansas City questionnaire. Patient lost around 6 kilograms weight. key, so no leaks and good motion of the TricValve leaflets, and also the patient, we could reduce the intensity of the diuretic therapy. Now the patient is only with furosemide 40 milligrams per day. Also the renal function improved, probably because we give less furosemide. This was how look like the inferior vein cava 3 months follow-up. So it's all, it was much more conventional case than the previous ones. That's all. So thank you very much for your attention, for your time.
Thank you very much, Dr. Omar. It was really nice of you to show the step-by-step approach, which is extremely important, and also show how important the pressure tracings can be. From a ventricularized pressure tracing of SVC and IVC, you get into a real, good traces, which itself tells you the success of the procedure. You don't have to possibly, do echo and all that. You have done the job. Obviously, you're going to do echo. Obviously, you're going to do an angio. That was fantastic. And with that, I think we come to the end of the formal presentations. We have a number of questions on the chat box, and we have, our panelists who can intervene and ask questions and give their comments. Some of the questions which I think are important, some of them have already been answered by, Dr. I think our friend Dr. Santos has already answered some of them. One was the question that, what about pulmonary hypertension if the patient has? I think the answer is very clear that it's not meant for patients of severe pulmonary hypertension with tricuspid regurgitation, because that's a contraindication. And other thing which is I thought was should be brought into all the experts is, what are the unsuitable anatomies of the vena cava? Where, are there any unsuitable anatomies? You will not venture into it, or you would, think about it, make the valve as per the, tailor it and, get some final different shapes and all that. Maybe Katharina Kiss could answer that if she's there, or Dr. Santos, who has so much of experience.
I think as Dr. Amat-Santos is our CT core lab, or part of our CT core lab, I think he is the best person to answer it, because he has seen a lot of anatomies by now. So, okay. Ignacio.
Okay,
yeah.
So as I mentioned in the presentation, one factor to take into consideration is if superior vena cava is very short and very taper, so like this, which will promote that the strength of the belly of the valve, make it more dangerous to embolize the valve if we are not able to position very high. But Dr. Kumar showed very interestingly one situation that happens relatively often, that is stenotic jugular vein. We saw one of the cases where they position the wire in the nominate. Probably the best position there is in the subclavian, in the left subclavian, sorry, in the right subclavian, so the same side. So we can advance the delivery system and deploy high, even if we cannot advance it to the jugular. So that's the correct way to position it. And for the inferior vena cava, the distance to the hepatic veins is not a problem. We have done it in cases with 4 millimeters, 3 millimeters to the hepatic veins, which is a contraindication for the alternative device. But if the vena is very angulated in the entrance to the atrium, this is a risk, not a contraindication, but the vein is like this and the delivery system is like this. So when we finally deploy, the valve will make this movement, will bend to adapt to the vein. So we have to do it very controlled, position very low the prosthesis, and before final release, as Omar mentioned, we have to release all the tension that we are doing pulling back, so that there is not this jump, that there is no elastic energy towards up. Other than that, I don't see contraindications for the device.
Right. Now, the other set of questions, especially one of our friends, Dr. Manoj, has been asking the repositioning. What are the methods of repositioning? Some of them were very nicely shown by Dr. R.K. Jain while he was doing it. Everything did not succeed, but he could push and pull the valve. And he also feels that can there be some anchoring spikes at the valve like we have in the IVC filters, to catch hold of them. Yes. Yeah.
Maybe let me answer the second question
Yes.
first. Of course, we have taken a lot of considerations when we were designing the TricValve design, which is a very dedicated design. And we feel that in the venous wall, any kind of spike might be very prone to injuring the wall. So that is why we stay away from this. The venous wall is very delicate, and I think when you touch the valves, they do have a radial force, but are still quite soft at the same time, especially the bigger they get. If you touch the 41 IVC valve, this is actually a very soft valve, which still has to have the radial strength, of course, to stay in place. But in the venous environment, it's a very delicate environment. So that's why we decided not to use any spikes or any anchors.
Okay. Yeah.
And I think for the repositioning, I mean, Omar, you also have a lot of experience with this. We normally prefer to retrieve the valve in a conventional way. So that means we reposition it within the capsular. I mean, I am impressed, and I was at that time when this happened, by the spirit and by the simple handmanship that they were applying, because I think it's just they did a very logical approach. The valve was migrating. What can I do? And I think this is fantastic to see how this was solved. But maybe Omar, you want to say something about the retrievability?
Yeah, well, the device is retrievable until the 80% of the device is deployed. So in our experience, it's better just to do a very slow deployment. Start with a high position. And if you want to replace, you want to put in a different position the device in a higher position, it's better to retrieve all the device and start again in a high position. It's what we can say. It's easy to go to pull down the device at the same time that you are deploying you are deploying the device, but it's better to don't push up the device when after you have gone down, because you can pinch the vein wall. So the recommendation is start in a high position, pull down. If you want to go up, just retrieve all the device and start again. So you can do this until the 80% of the device is deployed.
Right. The other
call, I have a question for Katharina. Can I ask?
Yeah, why not? Of
because
course.
It's very important. Katharina has highlighted that you have to do this therapy in patients where before they reach a no point of return. Can you identify these patients clinically where you think there are no point of return?
Well, I think we are learning a lot about this. I mean, for sure, right ventricular function plays a role. I think that liver congestion and the size of the IVC might give you some idea about it, although I have to say there are so many comorbidities that influence this, that this alone is not the reliable factor, because, for example, we were treating patients with liver congestion or with Chagas disease who benefited a lot. So I think it's the right ventricle in principle that has to be still viable, so that we can assume that it can cope with the remodeling and that it can let the patient benefit. I think other than this, I mean, of course, the more progressed we are in the course of disease, the longer the patient was having repeated rehospitalizations for heart failure, the more difficult it will be. But I think that is a very important question, and this is actually the question that we will have to answer for within the next months and years, because this is absolutely not answered now. So I think it's just certain factors
Katharina, just one suggestion, and just whatever little experience I had, those 3 patients whom were not doing well. So if you have a albumin like 3.5 is a normal range, if it's something between 3.3, 3.4, and the echo texture is something like pre-cirrhotic, you have to be a little careful in selecting those type of patients for this therapy. You think that's correct approach, or what do you think? And other
Well, I mean, just I think today a paper was published where actually a patient we did many years ago was saved from liver transplant because of TricValve implantation, because it eased the cirrhosis. So I think this is also not, this alone is not the marker, because if you want to treat symptoms, then TricValve, especially in this case, the inferior vena cava, is, I think, a very good treatment to relieve the patients from symptoms. So this alone is not the point. I think it's really the core, the combination of right ventricular function, the V wave as a sign of backflow, which of course has to be present in order to guarantee that the valves are working properly. I don't think that cirrhosis is a problem unless it influences anticoagulation, the anticoagulation regimen. Because this is something that I really want to stress. The patient should stay on lifelong anticoagulation because of the valves in the venous system. Ignacio, do you have anything to add to that question? Because I think it's a very important question, definitely.
Regarding the selection of candidates, I think it's very, TAPSI is not a very good parameter because it depends on the regurgitant volume and the stroke volume of the right ventricle. So if you use these 2 parameters, regurgitant volume and stroke volume, this is very useful to identify how good the right ventricle is, or by using magnetic resonance as well. You can have a good picture of the right ventricle. And this is useful for all patients except for congenital disease, because in those patients you might have good TAPSI, but a very restrictive right ventricle. So we need to be careful. Like I think you saw one case, and in those cases, it's even more challenging to understand how the right ventricle is going to react to this. And regarding the antithrombotic treatment, I think anti-vitamin K, vitamin K inhibitors should be the standard for these patients.
Yeah, so there are, many gray zones, and which I think, I'm sure with the passage of time, we'll come to know which are the optimal patients and which are the suboptimal patient. But the therapy is meant for these sick patients. So you can't say that he is too sick to be operated unless, RV is totally impaired and, and he has many other comorbidities. Still, you will caution the family and hope that some recovery would come. And then, as Katharina said, that cirrhosis early stages getting reversed also. So I think it's too early in the day to have those sharp, compartments. This is for it and this is not for it, unless the patient has PAH. And can you tell me what is the upper limit of pulmonary artery pressure? You would, say that okay, go up to that. Dr. Kirimat has this question. Yes.
In the clinical trials, we took a cutoff of 65 because, of course, in the clinical trial, we didn't want to get a heterogenic picture, because we wanted to exclude patients with primary pulmonary hypertension, and we wanted to make sure that with the patients selected, we have a rather homogeneous patient cohort. So 65 was chosen like in a consensus of the treating physicians. But, and I think it makes sense. I think for the moment, I would stay with that value. But anyway, difficult patients, I think we need to discuss whether we see a benefit. But up to now, we take 65 as a cutoff.
Just again, yeah.
Yeah, please.
Yeah, sir. So just I think one question, I think which also popped up, which came into my mind. If just we put an IVC component, will that, like in a patient who is getting cirrhotic and we were discussing, he's getting congested, just putting the IVC component, does it help, or we need to put both the SVC and the?
Well, I would treat both actually, because otherwise you get a redirection of the pressures. But of course, the IVC component, those patients will definitely help more. Like we are treating patients with Chagas disease in Brazil, who also have a problem which is more pronounced with ascites and with peripheral edema due to the biventricular cardiomyopathy, and they benefit a lot. So I think I still would put the two valves, because otherwise we might have a redirection of the pressures. But yes, and from the experience we have until now, it helps.
Great.
Thank you. Thank you.
Paravalvular leak, which could be a problem, and if there's a significant paravalvular leak, have any of you done dilatation to, oppose it? Is it
No, I wouldn't.
Because
I wouldn't dilate it because, as I said, it's a self-expanding structure. Yes. We have done one case where we have put a coil in Spain outside the stent because we had paravalvular leakage. Otherwise, I think so. Post-dilatation is not appropriate in this set of valves.
Okay. The other thing is that it's a low pressure circulation, and pressures are going to be low. But is there any chance of over a long term in young people, especially, to get degeneration? Any in vitro studies on the valve?
I think, look, we are working our way down. I think it's the same as with TAVI. Of course, most important is to prove the longevity of the pericardium and the device. Here, of course, we're doing all the preclinical, we're doing a lot of shelf testing, and because this will be the main determinant how young the patient can be for the implant. So I think this will be the most important. How long do we think that the valve will be appropriately working and functioning? And this is what we will have to find out and to push the limits within the next years.
Good.
And can I ask one, like the anticoagulation vitamin K antagonist, or the DOACs will also do? Like,
well, until now, we recommended the patients to be on vitamin K antagonist 3 months after the procedure. But afterwards, it was left over to the physician's distinction to switch them back to NOAC. So I would say the majority of the patients are on novel anticoagulants. I mean, if you remember the baseline demographics of those patients, then a good part of those patients had mechanical valve replacement on the left side. So this part was anyway on vitamin K antagonists. For the INR, or for I would say it's the same as for thrombus, for venous thrombus prophylaxis. So it should be between 2.5 and 3.5 for the international units.
Great.
Because that was a question that just popped up on the chat.
Yeah. I just saw it. So I think we have discussed in depth. We have discussed most of the aspects which were coming in our mind. And it was a very teaching and learning experience. And we hope that we're going to get more experience with many centers in our country. Our country is huge, 1.2 billion population, and a lot of tricuspid regurgitation. And I only think that the cost effectiveness of the procedure should also come down with the volumes if they are, implanted.
This is how life is. I just want to answer one more question of the chat, because I think it's also important for our Indian way. That was the question if the device will be brought to US. And there we are very proud that we have been granted the FDA breakthrough device designation recently. And actually the Cleveland Clinic will be our PI and our main trial center. So we're very proud about this.
That's a very good news. Yeah.
Yeah.
Because US FDA, as everybody knows, is one of the toughest regulatory bodies.
That's true.
And it's a huge market too, for the company.
Yeah. Also true.
Yes. Great.
Thank you very much again. It was a great.
I think we had a very nice interaction, and I wish all of you a very nice evening and have good time, and let us have this COVID away and meet.
personally.
Virtual meetings are good,
yeah.
But I think we need to have some physical meetings where we can see each other and touch
Definitely. Definitely. Can't wait to catch a plane to India, I tell you. Yes.
Great.
Looking very much forward.
Look forward to see all of you.
Thank you very much. Thank you.
So
Thank you.
Vote of thanks by our hosts.
So I would request our colleague, Mr. Kennedy, to convey his thanks to the participants and the faculty.
Well, on behalf of Relisys Medical Devices, we take this opportunity to thank all of you. Our chairperson who has guided us through this full session, Dr. Professor Upendra Kaul, our moderators, Dr. Rahul Gupta and Dr. Mir Jamal, our speakers and presenters, Dr. Katharina, Dr. Amat-Santos, Dr. R.K. Jain, Dr. Ramdas Nayak, Dr. Omar Abdul, and all of you delegates and attendees. Thank you very much for being part of this initiative of Relisys Medical Devices. And we hope to look forward to seeing you and catching up with you again in some more of these sessions in future. Thank you and good night.
Okay,
Next webinar
all
would
the
be
best.
on-
Thank you. Thank you.
Thank you very much.
Thank you.
Thank
you
you.
so much.
Good night, sir.
Good day to all
Thank you.
from Europe and US. Good day to all of us from India. Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you.
Bye. Bye.
Bye.